but a very important topic. You can see here as we see the structure of bacterial cell, as we see the structure of mycobacterial cell. Similarly, we are here seeing the structure of fungal cell. Fungal cell. So there are some differences which you can notice in what is difference. Like there is mycolic acid in mycobacterium, which is not there in a normal bacteria, and hence there are some different drugs for treatment of TB. Similarly, here you can see the structure of the fungal cell, where you can see proper cell membrane and cell wall. There is cross-linking of beta glucan, which is beta 1,3 and 1,6 glucan. Then there is a layer of chitin, and then innermost layer is of phospholipid bilayer of cell membrane. So cell membrane is there, cell wall is there, just like any other living organism. And then these there are some enzymes which are responsible for synthesis of these membranes, like ergosterol. This is a very important part of fungal cell. That is, you will find ergosterol incorporated in between the cell membrane. So thus as you can see here, phospholipid bilayer of cell membrane, there are ergosterol incorporated in between. So this is a peculiar thing about fungal cell, that it contains ergosterol. So it needs some enzymes to synthesize ergosterol. And then there is DNA RNA synthesis in the nucleus. So this is how we see it, and it is very, very good to see this cell wall structure, because here only we are going to read the mechanism of action of all the available drugs, which are very, very simple. You can see here, this is amphotericin B and statin. The amphotericin B is the hero of this topic, basically, but not very commonly used. But amphotericin is actually life-saving drug in fungal infection. Otherwise, the commonly used drugs you will see are conazoles, ketoconazole, fluconazole. You might have came across these names earlier as well. So this is amphotericin B and statin. You can see it is targeting the ergosterol, basically. So we will see what exactly is the mechanism of action, but just here you can see the site of action of these drugs. So they are actually making pore in this cell membrane after binding to the ergosterol, and this pore will lead to leak out of some very important ions from cell death. Then there are two group of drug. One is azole and one is terbinafine, which are ergosterol synthesis inhibitors. So they inhibit the pathway of ergosterol synthesis. No ergosterol will synthesize, and there will be weak phospholipid bilayer, and the fungal cell will die. The fungus will die because the fungal cell is not having enough ergosterol to hold on the phospholipid bilayer. Then there come a group called echinocandins. We will see that they are inhibitor of this enzyme beta glucan synthase, which is responsible for synthesis of beta glucan, which you can see here is responsible for cross-linking and provide strength to the cell wall of the fungal cell. Then there are some drugs like grisofulvin and 5-flucytosine, which acts at the level of nucleus, and they will act by different mechanisms, which we can see again as we go ahead. So this diagram, just remember, we'll see it again. I will show you it again and again to to understand the site of mechanism of action of the drugs which we are going to discuss. Now, classification on this basis only, which is very, very easy, which we already discussed. As I said, a group of drug that binds to ergosterol and increase membrane permeability. So here comes this drug group of drugs, polyene antibiotics, that is amphotericin, statin, hamicin. Out of these, you can see the statin is not very commonly used for systemic infection because of lot of toxicity. It is reserved as an ointment or topical preparation to treat some fungal infections. Then as I said, there are two group of drugs. One is flucytosine and one is grisofulvin, which acts at the level of nucleus. So grisofulvin mechanism is disruption of mitotic spindle. It acts by disruption of mitotic spindle and hence lead to cell death. And inhibition of nucleic acid synthesis like DNA, RNA by flucytosine is the drug. So along with the classification on the basis of mechanism of action, here is the classification based on structure is also written, which is just to remind that what exactly is amphotericin is polyene antibiotic, and what is flucytosine is an antimetabolite. Then inhibition of ergosterol synthesis, you can see two group of drugs. We'll see one by one. One is azole group, which is subdivided into two groups, imidazole and triazole. So the drug ketoconazole, oxyconazole, miconazole, and clotrimazole comes under imidazole subgroup of azoles, and then fluconazole, itraconazole, voriconazole, and posaconazole comes under triazole group subgroup of azoles. So this is one group of drug which is inhibiting ergosterol synthesis. Another group of drug is terbinafine. So this allyl amines, terbinafine and butanafine, is the another group of drug which is inhibiting ergosterol biosynthesis by acting on another level of the pathway. We'll see it when we discuss terbinafine. Then inhibition of fungal cell wall synthesis. As I said, there are a group of drug echinocandins which is inhibiting beta glucan synthase, which is responsible for synthesis of beta glucan, which is important for the cross linking and providing strength to the cell wall. The group of drug in echinocandins comes as caspofungin, anidulafungin, micafungin. So not all the names you need to remember, at least one, the first name which is written in every group. It is very, very important so that you at least understand what, if somebody tells you about what is caspofungin, you at least get it that it is an antifungal agent. Apart from that, because as I said, there are a lot of skin eruptions by fungal infections and very easily treatable. So there are a lot of topical agents and antifungal agents are available, like tolnaftate, undicyclinic acid, benzoic acid, cycloproxolamin. So there are various ointments and creams, lotions are available for antifungal treatment. Whenever you see something, some drugs or some tubes, creams at your home, or whenever you visit somewhere where you just try to find out what kind of content in it. If you find the content, and for example, if you find benzoic acid is the content in that cream, you might know that this somebody is using antifungal agent. So you will get this knowledge that what cream content, whatever topical agents contain what kind of drug, so that you can find out maybe there is someone in this area or in this house who are suffering from some fungal infection. Like that, it is just a big thing to know that just by seeing the some drugs, you can find out what kind of infection is going on in that, because these infections are contagious as well. So you might protect yourself by knowing this. So here we start with our prototype drug, that is amphotericin B. You must have uh, come across this term amphotericin, uh, and you know that it is antifungal agent. It is obtained from Streptomyces nodosus, and it is amphoteric in nature. Amphoteric in nature, that's why the term amphotericin is given. Amphoteric in nature means it has both the part, hydrophilic as well as lipophilic part. That is the ampho means both. Ampho means both. So because it has both hydrophilic part as well as lipophilic part, that is polar as well as non-polar. Uh, Hence, it is known. It is its nature is amphoteric, and hence the name amphotericin B is given. So this is the structure you can see. We are more interested in the mechanism of action, not in the structure. Just by knowing that it is amphoteric in nature is enough for us to know, so that we can say that we know that why this name is given to it. Now, if you see the mechanism of action here, it is very, very simple two-step mechanism of action. First, amphotericin B, because it is having both the polar and non-polar, and in its structure, it interacts hydrophobically with ergosterol in fungal cell membrane, and it forms a pore. Means by binding, you can see here in the picture that two molecule of amphotericin, they bind hydrophobically with the ergosterol here also, and they will create a hole, a pore in the cell membrane, which is otherwise very not very permeable. So now the permeability is increased and some small molecule like potassium, it leaks out. Because of this leaking, there is a it leads to the cell death. Okay, so this is a simple mechanism of amphotericin. If you can see, I already told you this is the site where amphotericin B and statin is acting. So here it is binding with the ergosterol and creating a pore. Okay, so if we go through the flow chart of this mechanism of action of amphotericin, we can say that amphotericin B binds to the ergosterol in fungal cell membrane, which form a pore in cell membrane, which leads to leak out of the cell contents like potassium ion. It leads to cell death. This is a very simple mechanism of action of amphotericin, and there are some cases of resistance to amphotericin has been noticed. The mechanism of development of resistance is either there is decrease in membrane concentration of ergosterol. So fungus got to know that there is something which is binding with their ergosterol and making a pore, so they are the cell is now producing less concentration of cholesterol, which is providing less binding target for the amphotericin, and hence there will be low efficacy and development of resistance. Replacement of ergosterol by other sterol in fungal plasma membrane. Second thing, what fungus can do is it can replace ergosterol with some other sterol. So your the site of binding is changed now, so drug will not act, and resistance is not a problem clinically. That is very rarely it has been seen that amphotericin resistance is, but this is the mechanism which might lead to development of resistance of amphotericin. If you see the pharmacokinetic, amphotericin is poorly absorbed orally, but still it can be given orally in some GIT fungal infection for local effect. So the drugs which are not absorbed orally, still given orally, consider it that it will not get absorbed from GIT. It means the target is GIT infection only. That is what we call as a local target, not the systemic one. Okay, so vancomycin is another example of the drug which is not at all absorbed orally, but still we give in pseudomembranous colitis to treat the GIT infection. So oral IV, oral vancomycin to treat the GIT infection locally. Similarly, oral amphotericin is given to treat the GIT infection locally. Otherwise, it is not absorbed orally. It should not be used. This route should not be used to treat systemic infection. It is insoluble in water. So colloidal suspension prepared with sodium deoxycholate. So we'll see this also. So normally the conventional amphotericin, it is a colloidal suspension of sodium deoxycholate amphotericin in 1:1 complex, just to because it is insoluble in water, to make it soluble, to make it useful, we need to add this colloidal suspension of sodium deoxycholate. 90% of amphotericin is bound to plasma protein. Every time, whenever somebody asks you, give me an example of a drug which is having high plasma protein binding. This warfarin and amphotericin, two drugs you should speak suddenly, stat, that these are two drugs known for their plasma protein binding. And what all those clinical significance which we discussed with plasma protein binding, that is, if there is a drug which is having high, it will displace another drug with high plasma protein binding and leads to the side effect. For example, if you give warfarin and amphotericin together, amphotericin will displace warfarin and warfarin will lead to hemolysis. It is metabolized in liver slowly and excreted in urine. It is, you will see in few slides that nephrotoxicity is a big issue with amphotericin uses. T half is 15 days. So here you can see in this picture that minimal penetration into CNS, vitreous humor, amniotic fluids. It can be given by IV route. It can be given topically, right? There is some elimination of amphotericin by a while, and part of those appear in urine over long period of time. So it is there in urine for long period of time, and hence it is very toxic to the kidney. Here you can see the antifungal spectrum of amphotericin, and actually it is a broad spectrum or you can say the broadest spectrum antifungal drug. It covers almost all the species of fungus, and it is fungicidal at high concentration and static at low concentration. So when you need to see its cidal action, you need to give it in high concentration by parental route. So you can see the spectrum here, aspergillus. So this, I hope you know what is aspergillus, what is blastomyces, candida, cryptococcus, coccidiomycosis, histoplasma mucor. This all you need to read from your microbiology. Everything about these fungus, and obviously it is a very important topic as far as microbiology is concerned too. So and not only in this fungal infection, it is also active against Leishmania infection. We'll see when we'll see this antihelminthic, you will find this in the treatment of Leishmania. Antiprotozoal, other antiprotozoal, not this means amphotericin, apart from having antifungal action, it is also having some action against the protozoa, that is in Leishmaniasis we can use it. Here is the administration and dose, which the dose you need not to remember, but which dose, which route is we are using for which infection. Like for systemic mycosis, if there is systemic fungal infection, means if there is infection in some organ and in deep tissue, we need to give amphotericin by parenteral route. Then intestinal monoleucosis, as I told, it is not absorbed orally, but still in one condition we are giving it by the oral route, that is intestinal monoleucosis. That is, there is a fungal infection in intestine, and we are giving it for local treatment there, because it will not get absorbed from GIT, it will remain in GIT and will treat the intestinal monoleucosis. Then topically it can be used for vaginitis, that is the infection and inflammation of vagina because of the fungus. Automycosis in fungal ear infection, so some 3% concentration of ear drops are available. And then in meningitis as well, it can be used by intrathecal route. So for amphotericin, you need to remember it is a broader spectrum, can be used for all the fungal infection, as well as it is available in all the possible doses form, oral, topical, intrathecal, intravenous. So it is a very, very important and very, very we are dependent on amphotericin in many fungal infections where not other antifungal drug can be used. So the uses you can see here of amphotericin is very important to remember, that it is a useful drug in nearly all the life-threatening mycotic infection. Although we do not use amphotericin very commonly because of its toxicity, but for life-threatening infection, we do not have any other option but amphotericin. For example, aspergillosis, not all the antifungal agents are active for invasive aspergillosis. We will see some itraconazole and voriconazole are effective, but otherwise amphotericin is the only choice left. Then for some rapidly progressive blastomycosis and coccidiomycosis cases, then in Cryptococcus neoformans, mucormycosis, you might have heard of black fungus, white fungus during this COVID era, post-COVID black fungus infection. So this mucormycosis is that black fungus, and candida is basically white fungus. So for mucormycosis, most of the antifungal drugs apart from posaconazole and amphotericin are not useful. So only two options we have: posaconazole one, which belongs to azole group, and other one is amphotericin. Then in histoplasmosis, and not only that, it is useful in treatment of kala azar, that is black fever. So we'll see that Leishmania treatment. Just remember one more use of amphotericin apart from fungal infection is this Leishmania. And topical uses of amphotericin, keratomycosis and otomycosis we can use. Mostly we have very good other topical agents also. So adverse event for amphotericin is very, very important to remember. So there is one is acute reaction and one is long-term toxicity, you can see. So acute reaction with amphotericin parenterally, mostly when we give this, chills, fever, headache, pain, hypotension, nausea, vomiting, dyspnea can happen. So this is actually very, very acute reaction because of some inflammatory mediator release like interleukin and TNF. So it is recommended that whenever you are giving this drug parenterally, amphotericin, the patient should be pre-medicated with some antipyretics, antihistaminics, and steroids to cope up with this acute reaction. It is recommended, and it is the proper precaution should take care before starting the parenteral amphotericin. Apart from this acute reaction, some long-term toxicity, as I told you, nephrotoxicity is very well associated with amphotericin use, and it is a big actually challenge for us to give amphotericin to the patient because of this nephrotoxicity. So, because of the nephrotoxicity, azotemia, hypokalemia, acidosis, yeah, decrease GFR can be seen, anemia can be seen. Apart from these nephrotoxicity and acute reaction, CNS toxicity is very well seen with evident with the intrathecal use of amphotericin, which leads to some headache, vomiting, and nerve palsies, which is very rare but is there. And then hepatotoxicity, because it metabolized in liver, so rarely it can lead to hepatotoxicity as well. So, what are the disadvantages of amphotericin B? So, one is nephrotoxicity. Second is acute infusion related reaction, as I told you, chills, fever. So, it is very important to pre-medicate the patient. And then finally, hypokalemia, anemia, hepatic dysfunction, because of nephrotoxicity only, can be seen. So, this is because of conventional amphotericin. Now, to overcome these side effects, not fully, but relatively less side effect with some newer preparation of amphotericin, and these newer preparation are lipid formulation of amphotericin B. So far, three lipid formulation of amphotericin B are available. One is ABLC, that is amphotericin B lipid complex. One is ABCD, that is amphotericin B colloidal dispersion. Then LAB, that is liposomal amphotericin B. Just remember the name only, that these are the lipid formulation of amphotericin B available. Then we will see some advantages of this over conventional amphotericin and disadvantages as well. So this is first one, ABLC. It is having 35% of amphotericin B incorporated in ribbon-like particles of dimyristoyl phospholipids. So here in this ABLC, the lipid complex we use it dimyristoyl phospholipids. So it is okay. It's not, there is no need to remember, but if it remains with you, it's okay. Just remember the name ABLC is available. So here you can see the photograph of ABLC in the inset. Certainly, Ansh, the pre-treatment with corticosteroid is not recommended in all the cases. It is totally dependent on the patient's condition, and whatever, if, as you say, there are some opportunistic infection, fungal infection because of immuno compromised status of the patient, and if in those patients we give steroid, it will further suppress the immunity. So no, when we give amphotericin, just to protect the patient from acute reaction, in that cases when we give corticosteroid, the dose of corticosteroid is not substantial and the duration is not substantial that it will cause further immunosuppression, just to suppress that acute phase reactants at that point of time when you uh, parenterally injected amphotericin is taken care by corticosteroid. So yeah, it is safe and it is always under supervision. Whenever we give corticosteroid, it is always a patient is admitted in critical care unit and we are giving under supervision this parenteral administration of amphotericin. So the hair corticosteroid can be used safely because you are using a single shot corticosteroid maybe just to control the acute phase reactant that is seen in the blood because of parenteral amphotericin. Just to control that we can use, but still we have other options as antipyretic just to cover up the chills and rigor that can be used. And if it is contraindicated, we should not use corticosteroid. So it totally depends on the patient condition. And yes, for most of the cases, corticosteroid is safe to give even in opportunity, even if the person is immunocompromised status, just to control the acute phase reactants by parenteral administration of amphotericin. So here we are not using corticosteroid for long. So this is one thing. So as we are discussing the lipid preparation, ABLC I told you, just remember 35% amphotericin B इसमें होता है और अगर आप याद रख पाओ तो it's good to know that dimyristoyl phospholipid is something which is there inside it. Then comes the other one, ABCD. The full form is Amphotericin B colloidal dispersion, and it is that वो ABLC ribbon shape का था, ये disc shape होता है, and इसमें 50% एम्फोटेरिसिन बी होता है, उसमें 35% था, and वहाँ पे माइरिस्टोल था, यहाँ पे कोलेस्ट्रॉल ईस्टर है. So this is enough to remember these three things: the full form, the percentage, and the phospholipid which is there. Then comes the liposomal amphotericin B, which is the small unilamellar vesicles. Actually, this is one of the greatest example of nanotechnology, which is nowadays booming because of their targeted approach to the tissue and less toxicity, more efficacy, very less side effects. But obviously, the cost is one of the problems. So 10% amphotericin B is here incorporated in this small unilamellar vesicles, which is made up of lecithin. So 35% ABLC, 50% ABCD, 10% liposomal amphotericin B. Okay, this is the difference in these three. यहाँ पे lecithin है, यहाँ पर cholesterol ester in ABCD, and then dimyristoyl phospholipid in ABLC. These three things you should remember. These are new one. The disadvantage of all this lipid formulation is you can see they are 10 times more expensive than amphotericin B deoxycholate, which we say a conventional amphotericin B. So now comes the exact problem. We want to give amphotericin B to our patient. We know that our conventional amphotericin B, which is amphotericin B deoxycholate, is very, very toxic to the patient. It may cause to permanent damage to the kidney. Other option we have are some liposomal preparation, but they are 10 times more expensive. And in our country, where patients are not having very good socioeconomic status, it is very difficult to give them liposomal amphotericin B. So cost benefit analysis we need to do, and that is how we are proceeding. And actually, mostly we are not able to afford liposomal or lipid preparation of amphotericin. We ourselves, as a doctor, are not able to afford it, so we go through. We use mostly the conventional amphotericin. So, what are the major advantage of lipid preparation of amphotericin over the conventional deoxycholate one? So, acute reaction will be milder, so there is less chance of acute reaction, which is good. Second is can be used in intolerance to conventional preparation if there is intolerance because of these acute and chronic side effect only. Nephrotoxicity is relatively lower. It's not like it will not cause nephrotoxicity, but relatively lower than that of conventional amphotericin. And anemia can also be less. And this is very, very important because this nanotechnology is there. So they deliver targeted, tissue targeted approach. So it delivers amphotericin to the reticuloendothelial system of the liver and spleen. So useful in leishmaniasis. Also, so again, the concept is same. The liposomal amphotericin B is drug of choice nowadays for leishmaniasis, but because we cannot afford it in our India, it is not the drug of choice. Can be used in higher dose. So this is how you can see this liposomal preparation targets the tissue, so they can endocytose and then go into the liposome. Liposomal enzyme degrade this lamellae, SUV ka lamellae, and then the amphotericin B releases from macrophages. So it is very, very targeted approach. It will reach to the target, and very less amount of drug is able to show the effect, and hence the less side effects. But toxicity is a problem. So this is all about amphotericin. You need to know the mechanism of action, pharmacokinetic, adverse effect, uses, and lipid preparation of amphotericin, advantages and disadvantages over conventional one. This is all about amphotericin B. Then comes another drug from the same group, polyene amphotericin. So same mechanism of action, and because of high systemic toxicity, it is used only locally, as I told you. But sometimes it can be used for intestinal moniliasis. Also, just like we are using amphotericin. So it is poorly absorbed from mucous membrane, and it is available as ointment, cream, powder, tablets. Tablet is for intestinal moniliasis, otherwise topical preparation only. It can be used for prevention of oral candidiasis. It can be used topically for treatment of vaginitis. So these are the preparation available: oral, cutaneous, conjunctival. एडवर्स इफेक्ट इज जीआई डिस्टर्बेंस विद ओरल टैबलेट्स, अदरवाइज टॉपिकल के जो रूट के होते हैं, इचिंग या रेडनेस एट द एरिया वेयर यू आर यूजिंग दैट ऑइंटमेंट, you will see that. So this is about anesthetic. Then let's come to the another group of drugs, griseofulvin, which is nowadays no more used. It is obsolete, but it was the earliest antifungal agent which we are using, obtained from Penicillium griseofulvum, and hence the name griseofulvin given. Then comes its action, that it is static, not like amphotericin that had higher concentration sidal and it lower concentration static. No, static antifungal agent. And this is very good to understand that it is a systemic drug for superficial fungal infection. This is very important to understand what we are saying here. Systemic drug for superficial fungal infection मतलब ये है कि when you are giving the drug not by topical route to treat superficial fungal infection. For example, there is some skin infection and you are not using topical agents, but you are prescribing patient to take some drug orally which will treat, treat this superficial fungal infection. Then we called it systemic drug for superficial fungal infection. Systemic drug for systemic fungal infection are also there. So systemic, if you are giving the drug by systemic route, either parenterally or orally, it can be used for both superficial and fungal infection. But if you are using the drug with oral, with superficial route only, that is topical route, it cannot be useful in systemic infection. It is then for local infection only. So griseofulvin was the drug which was used earlier when there was no such superficial approach we had. Some topical agents were not there, so griseofulvin was used to treat superficial fungal infection. So it active against most of the dermatophytes, like all the tinea infections. It can cover, so you need to read about tinea. Dermatophytes concentrate it actively and selective toxicity. So all the fungus infected cell concentrate griseofulvin. So the toxicity was selective, and the resistance was because of loss of concentrating ability. Sometimes it can be seen. Here you can see the mechanism of action. As I already told you, it interacts with polymerized microtubules and disrupts the mitotic spindles. This is all about griseofulvin. To remember the mechanism of action, that by inhibiting the mitotic spindle, it is acting at the level of nucleus. Okay, not at the level of cell membrane or cell wall. So there are two drugs which are acting at the level of nucleus. One is griseofulvin, one is flucytosine, which we will see. Pharmacokinetic of griseofulvin is mentioned here, that oral administration, as I already told you, it is a systemic drug for superficial fungal infection. It is given by oral route as a drug tablet. Irregular absorption has been seen. And one of the good example of drug which absorption is increased by fatty foods, so it can be taken with dairy product like milk. It is concentrated in characterized tissue and hence selective. It metabolized in liver excreted unit. The half is 24 hour. Headache is most common and very, very common adverse effect with griseofulvin. Almost all the patients who receive griseofulvin complain of headache. Apart from that, GI disturbance is there, CNS symptoms like confusion, fatigue, vertigo is there, some peripheral neuritis, rashes, photoallergy is there. Transient leukopenia can be seen, albuminuria can be seen. Gynecomastia like ketoconazole we also see in azole group, which is responsible for causing gynecomastia. So griseofulvin, and so these are the side effect profile of griseofulvin you need to remember. And because of this toxicity and because of the availability of better antifungal agents, now the use of griseofulvin is obsolete. So it is used systemically only for dermatophytes. You need to know what are dermatophytes. You need to read it from your microbiology books. It is ineffective topically. The topical preparation are not available. Only systemic preparation are available. Duration of treatment depends on the site, thickness of keratin and turnover of the keratin. This is common for all the antifungal agents. Whenever you are giving treatment, the treatment duration totally depend on the site. थिकनेस ऑफ केराटिन, फॉर एग्जांपल फिंगर नेल है तो कम ड्यूरेशन का होगा, टो नेल है तो ज्यादा ड्यूरेशन का होगा, स्किन है तो कम होगा, लाइक दैट. टर्नओवर ऑफ केराटिन पे भी डिपेंड करता है. ट्रीटमेंट मस्ट बी कंटिन्यू टिल इन्फेक्टेड टिश्यू इज कंप्लीटली रिप्लेस्ड बाय नॉर्मल स्किन एंड हेयर एंड नेल. दिस इज अगेन वैलिड फॉर ऑल द एंटीफंगल ट्रीटमेंट. You should continue the treatment until the infected tissue completely replaced by normal skin, hair and nail. It's not like incompletely आप उसको छोड़ दो, then it will recur. Dose of the tablet of griseofulvin is 125 to 250 mg 4 times a day. Although the T half is high, but because the concentration you need to give it in high concentration, and you are giving the drug systemically to treat superficial fungal infection, that the concentration of drug at the tissue is very, very important to reach. That's why multiple times frequency of griseofulvin prescription was there. So now duration of treatment, you can see here, if there is infection of body, skin and scalp, 3 to 4 weeks of treatment at 125 to 250 mg 4 times a day. Then palm and soles infection, there is thick skin, so the duration increased to 6 to 8 weeks. Fingernail 6 to 8 months. Toenail 8 to 12 months. So earlier there was no such antifungal agents for short duration of treatment, so griseofulvin was used. But nowadays, fortunately, we have drugs which can be used to treat antifungal agent for less period of time. Duration of action is less, so obsolete. Griseofulvin use is obsolete now. As I told you, one thing you need to remember, it causes gynecomastia. Other thing is that they are inducer of cytochrome P450, so they interact with warfarin, oral contraceptive pill, phenobarbital, disulfiram like reaction can be seen with griseofulvin. These are some important white points as far as griseofulvin is concerned. Clinically, we don't use it much now. Then comes flucytosine. So another drug which is acting at the level of nucleus, and griseofulvin is inhibitor of mitotic spindle, but they are inhibitor of some nucleic acid synthesis inhibitor. You can see here it is a product and pyrimidine analog, antimetabolite class, so it get converted to 5-fluorouracil. So the 5-flucytosine is a prodrug that get converted to 5-fluorouracil, right? Now human cell cannot convert it to 5-fluorouracil, so it is again a very, very selective drug, because the cell which are infected with the fungus can only activate it, and there only it will show its action. Okay. Now, so adverse event which is seen with 5-FC are some bone marrow toxicity, GIT toxicity like nausea, vomiting, abdominal pain, which is common with all other agents as well. Alopecia is something which is peculiar, but can be seen with other antifungal drugs as well. We'll see that skin rashes, itching, and rarely hepatitis can be caused. It is used in combination either with Amphotericin B in cryptococcal meningitis treatment or with itraconazole in chromoblastomycosis. No monotherapy of flucytosine is indicated for any condition. It is either combining with Amphotericin B to treat cryptococcal meningitis, or it can combine with itraconazole to treat chromoblastomycosis. This is the only use of 5-flucytosine because it is having narrow spectrum of action. Here you can see the mechanism of action of 5-flucytosine. Because these are newer drugs, we need to remember that this enzyme permease is required for the entry of flucytosine into the cell, right? And this entry of flucytosine inside the cell is facilitated by Amphotericin B. That's why Amphotericin B ke saath flucytosine is used in treatment of cryptococcal meningitis. After coming inside, the flucytosine is converted to 5-fluorouracil, for which the enzyme cytosine deaminase is required, which is not there in human cells. So this activation is not happen in the cells which are not infected by fungus. Now this 5-fluorouracil converted to 5-fluoro-UMP, and this DUMP converted to trimonophosphate form and by the enzyme thymidylate synthetase. So this 5-UMP ultimately inhibiting the enzyme thymidylate synthesis, which is responsible for synthesis of trimonophosphate from this thymidine monophosphate from uridine monophosphate and form DNA. So this step where this enzyme thymidylate synthesis is acting is inhibited by flucytosine. So see, flucytosine prodrug entered inside the cell by the enzyme permease, entry facilitated by Amphotericin B if it is given together. Because it is given together, there is no other single use of 5-fluorocytosine. Then by the enzyme deaminase, it converted to uracil, and that it will inhibit the enzyme thymidylate synthase, which is responsible for conversion of UMP to TMP, which is important in synthesis of DNA. So this leads to inhibition of DNA synthesis and cell division. So this is the mechanism of action of flucytosine. Very important. Advantage of combination of flucytosine with amphotericin: synergism. because you can see here it amphotericin is facilitating the entry of 5-flucytosine, also reduction in toxicity of amphotericin. When we use flucytosine, the dose of amphotericin is reduced in treatment of cryptococcal meningitis, so the toxicity is reduced. Also, the duration of therapy reduced and chances of development of resistance reduced. So, this is the rationale of combination of amphotericin B and flucytosine. There are commonly asked question. Write down the rationale of combination of flucytosine with amphotericin. So this is these 4 points you need to remember and write and tell whenever this question has been asked to you. But there are a lot of difference between amphotericin B and 5-flucytosine that you can see. Amphotericin B is an active drug, 5-flucytosine is a prodrug. Amphotericin is a broad spectrum antifungal agent. Flucytosine is only useful in cryptococcal and chromoblastomycosis. That too, along with amphotericin and itraconazole, respectively. Amphotericin B is an antibiotic that is obtained from microbes, while flucytosine is synthesized in lab, synthetic. Amphotericin doesn't absorb only it never absorbs. So 95% bioavailability is seen with flucytosine. So we give amphotericin by parenteral route or intrathecal route in treatment of cryptococcal meningitis, and along with that we give some oral 5-flucytosine, which will reduce the toxicity and duration of treatment. Amphotericin B shows very high plasma protein binding, while 5-flucytosine is showing low plasma protein binding. Uh, Amphotericin B does not cross blood-brain barrier, so we need to give it intrathecally when we need to increase the concentration of amphotericin in meningitis, cryptococcal meningitis, while flucytosine can penetrate BBB, so can be given by oral route. Amphotericin metabolized in liver, while 5-flucytosine excreted unchanged in urine. So the toxicity with kidney may be increased with the use of both the drug, but because the dose of amphotericin B is reduced significantly when we are using it along with 5-FC, that nephrotoxicity is also reduced. Amphotericin is very effective. The efficacy of flucytosine is less, and amphotericin is available in all the form like topical, intrathecal, IV. Oral is also, but not for systemic infection. So here it is not written. While flucytosine is used by oral route. So these are the differences. So see the beauty of combination that amphotericin B and 5-flucytosine show synergism, even having a lot of difference between these two. So let's take a 5 minutes break and we'll start our azole after that, and we'll try to finish it in next 40 or 45 minutes. So here 3:54 is in my clock. We shall start at 4 p.m. sharp. So be there after 5 minutes. Thank you.
Okay, am I audible?
Okay, so let's begin here with the poll so that I can give you attendance. So again, I am launching a poll for next 2 minutes. All of you who will participate in it will get the attendance. So this is a very simple thing just to know whether you are there or not. So poll in progress now, and it is ready to collect the response. Please see whatever you find it correct or true or false. Amphotericin B is an ergosterol synthesis inhibitor. True, false. So out of 240 attendees, 241 now, 20% of you voted so far. One minute over, 39% of you voted, waiting for one more minute to go. Thirty seconds left. 52% of you voted so far. Last 15 seconds, 55% voting is done. Out of 250 students, only 57% voted so far. And so the poll is, I'm going to close this poll now. 57% voted, and here it closed. So 58% of 248 students voted for this poll and will get the attendance. And here 70% of you marked it true. This was a tricky question where I asked that amphotericin B is an ergosterol synthesis inhibitor. No, it is false. I never said it is a ergosterol synthesis inhibitor. I said it binds to the ergosterol where it makes a pore. So the important micronutrients leaks out and that happens. So ergosterol synthesis inhibit nahi kar raha hai. Ergosterol synthesis inhibitor, I told you there are two classes. One is terbinafine and one is azole, which